I'm Julie Shirley, Executive Editor of the Bellingham Herald. Thank you for joining us today for what I'm sure will be a lively conversation with caregivers on the front lines of COVID in Whatcom County. We have lots of questions from readers, and you can continue to post others in comments on whatever platform you're viewing on today. Joining us from Peace Health St. Joseph's Hospital in Bellingham are Dr. Sudhakar Karlapudi, nurse Cedar Anderson, and Dr. Kevin Lee. Reporter Dave Rosbach, who's been reporting on COVID for the Bellingham Herald since Whatcom's first case back in March 2020, will lead our discussion. Dr. Karlapudi serves as the Chief Medical Officer and the Patient Safety Officer for St. Joseph Hospital and Peace Health Hospitals in Skagit and Island counties. Dr. Lee is an Associate Chief Hospitalist at St. Joseph. He specializes in adult inpatient care and leads the hospital's COVID treatment task force. He's also one of the lead physicians caring for COVID patients. Also joining us is critical care nurse Cedar Anderson, who has managed the hospital's ICU COVID unit throughout the pandemic. We're delighted they could join us today. Now, let's get started with today's Whatcom COVID update from Dave Rosbach.
Thank you, Julie. Whatcom County just saw its largest reported increase in new confirmed COVID-19 cases during the pandemic on Monday, with the Washington State Department of Health reporting 248 new cases over the weekend. Overall, Whatcom County has had 11,542 confirmed cases and 758 additional probable cases reported during the pandemic. St. Joseph Hospital in Bellingham reported it is treating 37 patients with COVID-related symptoms Tuesday, which is down 2 from the record high 39 the hospital saw on Monday. Overall, Whatcom County has seen 584 COVID-related hospitalizations and 114 COVID-related deaths during the pandemic, according to state data. I'd like to thank our panelists for joining us today to talk about the past 18 months of the pandemic, what they're seeing now, and potentially what lies ahead for us all. Our first question goes to Cedar. Could you please describe how the COVID-19 pandemic has impacted what you do at the hospital on a daily basis?
Thank you, Dave. So how that has affected us in the hospital here is that we have had to change the configuration of multiple units, our ICU unit as well as our medical unit, in order to accommodate having these patients in separate areas from the rest of the hospital. We have extra PPE that we wear, and we've been blessed to have sufficient amount. We have not had to go without, and that has been amazing, supportive of our hospital system and our community here at Peace Health. But that is a lot of the changes that we've had. We've had to be more careful. We've been wearing masks, and we've just had to flex and accommodate to the changes that are sent to us by CDC and the guidance from our hospital.
Thank you, Cedar. Our next question is for Dr. Lee. What medicines and therapies are available now to treat COVID, and how has that changed since the earliest patients in March of 2020?
So we take direction, much like the majority of the hospitals across the country, from the guidelines put out by the NIH. Oxygen saturation is a vital sign that we measure in patients, which indicate the amount of oxygen traveling through someone's body in their red blood cells. And if a patient is coming into the hospital and needing to be hospitalized, their oxygen saturations are usually less than 90%. So the mainstay of therapy is supplemental oxygen to get somebody's oxygen saturation above 90. And if somebody is getting admitted for COVID, we have 2 medications initially used. The first one is called remdesivir with an R. It's an antiviral medication approved for use by the FDA in the treatment of COVID. It originally was used to treat hepatitis C, and now we're using it for COVID. We also use steroids, and we use a steroid called dexamethasone, and this is used to try to reduce inflammation in the lungs. If a patient has been hospitalized for about 48 hours and they're not improving and they have rapidly increasing oxygen needs, then we have 2 other medications that we can give. We can either give a monoclonal antibody called Tocilizumab or a medication called baricitinib. And what Tocilizumab does is it's a monoclonal antibody which binds to interleukin 6, which is part of an inflammatory cascade to try to limit the amount of inflammation in the body for patients with COVID. The other medication, baricitinib, also works in a similar mechanism. It inhibits other proteins in this inflammation cascade, which are known to be elevated in severe COVID. So remdesivir and dexamethasone we've been using for over a year now. Baricitinib we started using about a month ago, and tocilizumab we started to use that about 6 months ago. This is different than last year when COVID first started, when we weren't exactly sure how to treat COVID at the time. But now, as we have more information on COVID, we have better medications to give patients.
Thank you, Dr. Lee. And this next question is also for you. How sick are the people that are being hospitalized with COVID-related symptoms? What kind of paint a picture for what you're dealing with the patients that come in and as they progress through their treatment at the hospital?
Yeah, so the patients who have been admitted over the past month, which we assume are from the Delta variant, are quite sick. They're significantly more sick than patients prior to the last 4 to 6 weeks. We're seeing younger patients come to the hospital with no pre-existing medical conditions who are requiring high amounts of oxygen the second they step in the door. We have these patients are spending more time in the hospital. They're compared to the patients we had last year with prior variants, and they're requiring much more oxygen, and they're being hospitalized for longer periods of time. We're finding it taking more time to titrate down oxygen for these patients.
Thank you. Our next question is for Cedar and Dr. Lee, and it's from Hillary in Bellingham, who asks, and we'll start with Cedar. What has been the most difficult aspect of caring for COVID patients through the pandemic?
I think the most difficult aspect of caring for them has been the isolation that both they and the staff have. We have very early on, we set up an enclosed unit, an isolation unit, so that we could make sure the patients and the staff who are caring for them are safe. And so having that isolation and as our increased patient population in the community, or our increase of COVID patients, we have had to minimize visitors within the hospital. And so not having visitors allowed into the COVID unit because of initially not having high vaccine rates, and continuing with just making sure that we're not spreading, especially with this variant. And so it's been really hard on the nursing staff as well as on the patients to not be able to see their family members as frequently before patients could have visitors into the hospital. We have done multiple alternatives to have that communication happen. We have iPads in the COVID unit. We have that we can FaceTime with family. We have had support from pastoral care where they have been able to bring in additional devices for communication and have family conferences. But it really has been that feeling of isolation, I think, for the patients. And I think that's it takes a toll.
Thank you. Same question to you, Dr. Lee. How is what's the toll that you've seen from the pandemic?
Yeah, it's hard to pinpoint one exact, the most difficult aspect of COVID. It really is a combination of multiple factors. Obviously, watching people come into the hospital struggling to breathe, and ultimately watching some people lose the battle to COVID is the most one of the most difficult things that providers, nursing staff, respiratory therapists have to deal with. I echo what Cedar said about the visitor restrictions, and that's that those restrictions are put into place to protect the people in the hospital and the people in the community. But it's not just the patients who are COVID positive who have visitor restrictions. It's also the patients who are here for who are here not for COVID. And so that's very difficult, not having family and friends at the bedside with the patient, because they do play a big role in helping somebody get through their hospitalization, especially for patients who can't communicate very well, who need their families to help retain information and to give them a pick-me-up during their course. It definitely takes a toll on the patients as well, makes them lonely, and we are seeing some patients struggle not having their family here. I think another difficult aspect is not knowing when things are going to get better. We thought that with the vaccines, we would have a little bit of light at the end of the tunnel, but you could argue we may not be in a better position than where we were last year when the vaccines were not available yet. So, caregivers, we're hoping that we get through this pandemic as soon as possible, but at this current time, we're not sure when that is, and that's very difficult.
Thank you, Dr. Lee. Dr. Carla Pudi, do you have something you'd like to add to that as well?
Maybe supplement Cedar's and Dr. Lee's reflection on what's most difficult. In the beginning of this pandemic, when we did not have the vaccines, we essentially were taking care of a disease that was not preventable. I think what's most difficult for me now is, hearing about young patients getting admitted and then subsequently dying from what is now a largely preventable disease is the one that I find most difficult, because the vaccines are so effective in preventing severe disease. So I just wanted to add that as something that we in healthcare feel that now it's actually a preventable condition, largely preventable condition.
Thank you. Our next question is also for the entire panel, and we'll start with Cedar. What toll has the pandemic had, and the wear and tear of battling this pandemic over the last 18 months, and how have you and your colleagues found to deal with that, and perhaps even come together as a team?
Oh, I think that the wear and tear that has happened I think it's globally on the hospital as well as on the community and on my team, as well as the other teams that collaborate with COVID. Some of what we have seen is, again, similar to what was happening, and the hardship of this disease is the isolation. Often, the nursing staff is also isolated within the COVID unit. They are donning full PPE, walking into a unit, and in order to go to the bathroom or get a sip of water or have a break, they then have to doff all of their PPE and leave. And that is added steps. In emergent situations, they have to make sure that they're properly dressed before they go into the unit. And I think that has been very difficult for my team, as well as the ebbs and flows of the entire disease process. We started, as Dr. Carla Pudi said, we started, not knowing where this disease process was going, and being able to care for patients, not knowing what the process was going to be in the sense of where we were going to go. Then being able to start the vaccination process, and the vaccination process showing that it was effective, and seeing some lulls, and now seeing the variant. It feels that we want to encourage more people to be vaccinated to minimize the illness. So I think that that's really been the hardship for the staff. I also know that they have come together and talked, and we've done debriefs just to talk about where we are, and trying to increase the little wins that we get when we do have a patient that is able to leave the hospital. So
Thank you, Cedar. Dr. Lee, would you like to talk at all about what the wear and tear of the past 18 months has been like for you and your staff?
Yeah, there are a lot of elements that play into the wear and tear. The first one being the emotional toll that seeing COVID patients have on us when they don't do well. Over the past few weeks, we have had patients decompensate very quickly and go to the ICU, and at times we go home that night. I go home that night, and I wonder if they're going to be there the next morning, and that's very difficult to comprehend. Somebody who could be so young, could be my age, healthy, and come to the hospital, and one day I'm seeing them, the next day they may not make it through the night. Our team is quite resilient. Us hospitalists, we have been doing this for about 18 months now, and we come into work and we go into the COVID unit, and we don't lose any compassion for what's going on. We are still empathetic for the patients' families, and doing this day after day, it takes a toll. It takes a toll on what we're seeing in the COVID unit, watching these patients struggle. I know Cedar just talked about her nursing staff, and I do have to commend all the nurses working on the COVID unit, as well as the respiratory therapists, environmental services, central supply chain, laboratory, phlebotomy, because I could be in the COVID unit for several hours a day, but these nurses are there 12 hours a day in full PPE, uncomfortable N95 masks, uncomfortable PAPRs, and they're spending so much time with the patient, then they go home to do it again the next day for 12 hours. It's very difficult on the body, very difficult on the mind.
Thank you, Dr. Lee. Dr. Karlapudi, do you have anything you'd like to add?
I think Cedar and Dr. Lee have touched upon the challenges. What I do want to say is that people who choose to join healthcare, in my opinion, have this core inner compassion and resilience that few other professions have. I think that calling to serve a fellow human being and to show that compassion has been something we have always celebrated and made it our focus as part of our care plan for our patients. And we make it a point to make sure we have conversations on these issues within the hospital, within departments, to make sure that caregivers have a way to express how they are feeling, and then also to ensure that if there are any other active issues that we need to help and support caregivers, we can elevate them. So I just wanted to add that piece to what Dr. Lee and Cedar had shared.
Thank you, Dr. Karlapudi. And kind of in that same vein, this next question for Cedar is from Lynn in Bellingham, who asks, besides getting vaccinated, how would you suggest individuals in Whatcom County show their support for the fine work and dedication our healthcare providers are doing?
I think the community has shown a lot of support in additionally getting vaccinated, but also, masking, being careful, because I think the hardest thing for us as caregivers is knowing that the patient is at our core and our center and a focus of our care, and any less patients that we can see, people that we can see coming into the hospital with this disease, it is a blessing. We want people to stay healthy. This, the hospital, we want you to enjoy your life, but also be able to support the larger cause. And I think that by being careful, masking, social distancing, getting vaccinated will help our team know that we're all in this together.
Thank you. Our next few questions are about the
David,
Delta
can I
variant.
add to that?
Oh, please do. Yes.
So just want to say a couple of things. if you have received your vaccine and had a good experience or you've had side effects, and I would say please share with that experience with those who might not have received the vaccine, because I think it's very important for people to hear the experience of those who have gotten vaccinated, so that they can learn from our experience, and then if they are making a decision, that will help them make a decision towards getting vaccinated. So if you're able to help us with that, please do share it with your family members, your social media, if possible, your experience. How did it go for you, and how are you doing now? The other thing I really want to emphasize on is please do not ignore your other health conditions. There are a lot of patients who have other chronic health conditions, so please do not ignore that. Please do not ignore other screening process, modalities to make sure you're getting your mammograms done. Please get your children vaccinated. So please do all those things. Please also focus on staying healthy, eating healthy, because those are the things that will keep us healthy in the long term. So didn't want the focus to be all COVID, because we need to take care of other diseases too. So wanted to share that.
Great advice. Thank you, Dr. Karlapudi. Our next few questions are about the Delta variant. And the first one's for Dr. Karlapudi, and it's a question from Catherine in Ferndale, who asks, how common are breakthrough cases now that the Delta variant has become so prominent, and how risky is it for vaccinated individuals to go out and eat?
Yeah, it's a great question. Very insightful question. Thanks, David. Yes, we know that the vaccines are very effective in preventing severe disease, but we also know that the vaccines are not 100% protective. They're about, so what we have started to see is that we have started to see breakthrough cases. What we know is that Delta variant is the predominant strain right now. More than 99% of the cases that we see from epidemiological data tell us that it's Delta variant. We know that when there are breakthrough cases, a large number of those breakthrough cases, the person who experiences that has only mild symptoms. But we are starting to see anywhere between 10 to 15% of patients getting admitted to us who are vaccinated. But here's the caveat. They tend to stay fewer days in the hospital. They tend to go home sooner. They tend to have very mild disease compared to those that are unvaccinated. So even though we are seeing breakthrough cases, we are seeing real life evidence that the vaccines actually are protective even in those situations when there are breakthrough cases, because those patients are actually going home sooner. They have even milder disease than those that are vaccinated. So it speaks to the continued efficacy of the vaccine in preventing serious illness with the Delta variant.
Thank you, Dr. Karlapudi. Dr. Lee, does the Delta variant present any different than earlier forms of COVID, and what new challenges does it create?
At times, the Delta variant seems like a completely different disease, actually, compared to last year. Like we commented on earlier, the patients are coming in younger. They're coming in requiring more oxygen than prior strains of the coronavirus. And I think one of the things I'm noticing is in the past, we've had more of a predictable hospital course for somebody who comes in with COVID. If they come in on oxygen, we can kind of predict when their oxygen is going to come down. We can predict when we can even turn it off. With the Delta variant and the patients we have here in the hospital, we're noticing their oxygenation requirement can fluctuate. They can be doing okay one day, and I can feel pretty good about them. Next day, they're requiring much more oxygen. So at times it feels like they're taking 2 steps forward and 2 steps back. So in the past, when somebody's oxygen requirement was on a downward trend, that would give us a good idea of when they could go home and when they would get better. But now we're seeing such fluctuations in a patient's hospital course. Some patients are getting better and then worsening again, and that is very concerning. Thank
you, Dr. Lee. Dr. Karlapudi, our next question is from Alice in Bellingham, who asks, in a vaccinated individual, if you contract the Delta variant, how many days do you carry the virus and could possibly pass it on to others?
Great question. If you're vaccinated and you've had mild disease, the data currently is telling us that your infectious and likely able to transmit this to another person for about 10 to 14 days. So it is still infectious. We know that the Delta variant it has got an R naught of 6, which means one person can infect up to 6 to 7 people in one exposure. So those 10 to 14 days are when the person with the symptoms is most infectious with Delta variant.
Thank you, Dr. Carl Pudi. This next question is also for you, and it comes from a Bellingham resident who asks, could you explain how the testing works to determine the Delta variant cases? And is there a specific test for the Delta variant?
That's a great question. It's a great question that's caused some confusion. So the current PCR tests that we have in the country largely are detecting for the coronavirus. What happens is that as we see a new variant, a certain proportion of these positive tests are sent to referral labs at the state and the CDC. And they run the genomic tests to actually understand what is the current circulating variant. And over the past 3 months, the state and the central government have done this work. They have looked at all the positive samples across the country, and they have looked at what proportion of these samples are Delta variant versus the original variant versus the Alpha variant. So based on the data right now, that genomic studies are telling us that more than 99% of strains that are circulating in Washington in Whatcom County is the Delta variant. But the caveat is the regular PCR testing that we get done is looking for just testing for the coronavirus. So between the two, we can safely say that the test is good in picking up coronavirus, and whatever coronavirus we are picking up, it's the Delta variant. I hope that explains it.
Yes, it did. Thank you, Dr. Kay. The next question is also for you, and it's from Mark, who would like to know about the lethality of the Delta variant. Is it significantly higher than other variants in fully vaccinated people? And is the age and distribution of related deaths pretty similar to the COVID, the original COVID virus we were fighting back in 2020?
Well, once again, a very astute question. The Delta variant is undoubtedly more infectious. It is undoubtedly more lethal. It is without question affecting younger people with fewer comorbidities than the original 2 strains did, the wild strain and the Alpha strain. The data on this is still being collected to understand exactly what is the mortality ratio and what are the age categories. But if we look at the age distributions with the Alpha variant versus the Delta variant, the data on the DOH site is very clear. We are starting to see a lot more people in their 20s getting admitted, a lot more people in their 30s. We are seeing a lot more people in their 50s who are actually dying from the disease with Delta variants, which tells us that this is a much more infectious and a lethal variant than we had the original variants. So yes, the exact numbers are still being calculated, but anyone who's taken care of patients over the past 18 months will tell you that this variant is far more infectious and far more deadly.
Thank you, Dr. Carlapudi. Dr. Lee, this question is from Rebecca in Bellingham, who asks, is it reasonable to believe that given the world's current vaccination rate, the rapidity of the spread of COVID-19, and the lack of precautions being taken in many places around the world, that another variant even stronger than Delta could emerge?
I think we cannot dismiss the possibility of a stronger variant being made. I agree with Rebecca that I look around the country and I see a lot of mass gatherings with patients who are unmasked, and that does concern us because it's kind of like some people have forgotten that we're still in a pandemic. And if you walk into any hospital in the country right now, you'll quickly be reminded that we are still in the middle of a COVID surge. So viruses are smart. They'll mutate. They'll learn how to adapt. And another variant in the future is definitely not out of the question.
Thank you, Dr. Lee. This one's for Dr. Carlapudi. Whatcom County has seen an increase in breakthrough cases in recent weeks, according to data released by the Whatcom County Health Department. Is this reason for concern that the vaccine isn't working?
I think I've answered this before. It is difficult to say exactly why these breakthrough cases are happening. I think we know that the vaccines are not 100%. They are really good, but not 100% protective. We know that the breakthrough cases are largely even milder disease, and those who are getting admitted go home soon. So I think it is too early to say that the vaccines are not working. In fact, everything that is telling us is that if you're vaccinated and you get COVID, the probability that you will survive this and go home is very, very high compared to those who are not vaccinated. So I would say the fact that we're having breakthrough cases and still we are seeing people go home to their loved ones is actually testament that the vaccines are still working. What we do know is that we need to get a large number of patients and people vaccinated to make sure that we can kind of stop this, creation of these new variants that Dr. Lee was concerned about. So I think that's the emphasis, is to ensure that we can get significant number of people vaccinated.
Thank you, Dr. Karlapudi. Dr. Lee, switching gears here a little bit to talk about monoclonal antibodies. What are monoclonal antibodies, and how can they be used in the fight against COVID-19?
Yeah, so I touched on this a little bit earlier, but I'll expand on this a little bit more. So monoclonal antibodies are medications that we have traditionally used for autoimmune diseases. They're antibodies, which are proteins, and there are several monoclonal antibodies out there used for COVID, and they each have a different mechanism of action. I talked about the monoclonal antibody that we're using for inpatients earlier, called Tocilizumab, and that is the antibody that is an IL-6 inhibitor. So IL-6 is a cytokine that is involved in this inflammatory response. So it'll try to inhibit IL-6 and reduce the amount of inflammation in the body during COVID. That's the monoclonal antibody that we're using as an inpatient. We also have the monoclonal antibodies, Regen-Cov2, and that's maybe synonymous with the Regeneron antibody. That is a monoclonal antibody. It's actually two of them that are used in combination, and they are antibodies that are used against the spike protein, which is made from COVID. So it will attach itself to the spike protein. It will tag it for our own immune cells to go and try to eliminate those molecules. Now, the Regen-Cov2 monoclonal antibody, that is reserved for patients who are not sick enough to be hospitalized. So the intent of this is, if somebody tests positive for COVID, they have pre-existing medical conditions and they want to reduce the risk of severe disease and reduce going to the emergency room, they would qualify for this monoclonal antibody. And here in Whatcom County, we've been fortunate to partner with Infusion Solutions, who is currently administering this medication as an outpatient. So if you know somebody, or if you test positive for COVID, you're at high risk for progression of disease, you can visit or call your primary care provider, and they'll be able to tell you if you qualify for this monoclonal antibody.
Thank you, Dr. Lee. Dr. Karlapudi, a lot of people have likened COVID-19 to the flu. Can you talk a little bit about the differences between the two diseases?
That is such a good question, David. Thank you for asking that. The COVID-19 is nothing like the flu. The flu essentially is a virus that infects the lung, and there you get flu-like symptoms and you get pneumonias with flu. COVID-19 is actually a virus that causes systemic inflammation. And when we talk about inflammation, think of it like systemic inflammation means that this virus is affecting almost every single organ in the body, not just the lungs. The lungs show the first manifestations because you start to get more short of breath and need more oxygen, but that doesn't mean it's not affecting elsewhere. It actually affects blood vessels. It causes vasculitis. It affects the heart. It causes myocarditis. It causes inflammation of the gut. We have started to see some late cases of CNS, the central nervous system manifestations of this virus. So there could be the COVID-19 and the disease it causes is nothing like the flu. It is far more deadly than the flu, and it leaves far more long-term consequences like the flu. So if someone is out there thinking this is just like the flu, they would be mistaken, because this virus is far more lethal and causes a significant inflammation, unlike the flu. Just going back to Dr. Lee's question, the monoclonal antibodies that we are actually using for treatment of COVID is trying to control that inflammation. It should tell us how important that inflammation is in the process of causing this disease. Unlike the flu, wherein the medication for flu that you can take 72 hours after exposure or symptom onset is actually purely an antiviral, and there's no role for anti-inflammatories in flu management. So categorically, COVID-19 is not like the flu and causes significantly worse disease than flu.
Thank you, Dr. Karlapudi. I'd like to shift gears a little bit and talk about treatment of COVID in the hospital. Cedar, we hear very often about patients being intubated. Can you describe what that process is like, and what it's like for a person who is put on intubation?
Yes. So initially, we attempt to prevent intubation. We will increase oxygen based on a couple of different mechanisms. We'll use a nasal cannula, we'll use BiPAP. We have a high flow nasal cannula, which is, for lack of a better way, is synonymous with some of the BiPAP. It gives some pressure as well as the oxygenation. Intubation is what most people would understand from shows they would see. It's a breathing tube, but it's also, if you've had a surgery where you've had general anesthesia, it's a tube that allows you to have assistance of oxygen and gives more higher oxygen and more support to the patient. We do everything that we can to prevent intubation, because we have seen some patients succeed with intubation and be able to be extubated, but we have seen a fair amount of patients that do not recover after intubation, and so that's difficult for the family, for the patient, and for all of us caring for them.
Thank you, Cedar. Dr. Lee, this is a question from Susan in Bellingham, who asks approximately what % of patients with COVID symptoms require a ventilator?
So right now at Peace Health St. Joe's this morning, we had 37 patients who are positive for COVID. 13 of them are in the ICU, and the rest of them are on our medical care unit. Compared to last year, we do have patients in our medical care unit who are on high flow oxygen, who are a little bit away from perhaps going to the ICU. So within those, I would say those 13 patients in the ICU may not capture the full extent of which patients will eventually need higher level of care. Right now, we have 6 patients out of the 37 who are on a ventilator, which makes up a little less than half the patients who are in the ICU for COVID.
Thank you, Dr. Lee. Another question for you. We've heard recently that from the Whatcom County Health Department that they're concerned by the younger ages of patients that are headed to the hospital, especially since Delta has appeared. What's the difference in treating COVID-related patients who are elderly versus those who are from younger age groups?
So there's no difference in the treatment that we give the patient. They're still on supplemental oxygen. They're still on the same medications I mentioned earlier, with the remdesivir, the antiviral, the steroids, the monoclonal antibodies. I think something that I've learned treating the patients who are younger, that we have to have the same degree of urgency, the same degree of concern for these young patients as we do patients in their 60s and 70s. We've learned that COVID does not discriminate. It will attack a young, healthy 30-year-old the same way it will attack somebody in their mid-60s. And we can't assume that because somebody is younger and healthier that they're going to do okay. We have to we have to give them the same urgency, the same level of care, and the same treatment standards as we do older patients. Older patients do come with a little bit more comorbidities, pre-existing medical conditions, so we have to factor that into how we approach them, how we treat them. As Dr. Karlapudi just mentioned, COVID affects all organ systems, liver, kidneys, heart, lungs, and it can cause strokes as well, cause blood clots. So patients with pre-existing medical conditions, we have to be very careful that their pre-existing conditions are being accounted for and being looked after.
Can I add to that, David?
Absolutely.
So one thing to keep in mind is that these medications that we use, they cannot be used, on every patient. We look at every patient to make sure they can actually safely receive these drugs. Most importantly, somebody with really compromised kidney function and compromised liver function, we cannot use this drug. So the docs are looking at every patient individually and making those decisions. So a decision to give a drug or not is not just blanket, but also basically understanding. So what happens sometimes is we find that patients, when they're elderly, tend to have more problems with their kidneys and liver, and therefore sometimes we might not be able to use the drug because of pre-existing health conditions than just age. So I just wanted to capture that caveat and supplement Dr. Lee's answer.
Thank you for doing so. And this next question is for you as well, Dr. Karlapudi. Hyder from Whatcom County asks, how many beds are available in the St. Joe's COVID unit? And could you please explain how the hospital can expand its bed space for COVID positive patients if needed?
It's a great question. As of today, we have dedicated 44 beds to COVID patients. And as Cedar and Dr. Lee said, we have currently have 37 patients in-house. From the very beginning of this pandemic, the team at St. Joe's has had a philosophy that we will expand our existing units to accommodate as many COVID patients as we safely can in a modular fashion. And we do this to take in what I could say sections of the hospital or modules of the hospital. And then based on how many number of patients we are either admitting or discharging, we can expand that capacity. And then if we see a decrease, we can decrease the number of COVID units. So it essentially a modular approach so that we can expand as the demand increases and then contract as the demand decreases. So we have a team that meets very regularly, and we have plans for sections in the hospital where we can continue to expand as we see this demand happen.
Thank you, Dr. Karlapudi. Dr. Lee, this next question is from Tracy in Bellingham, who asks, what are you recommending to patients who are fully vaccinated regarding traveling overseas during the pandemic?
Because we're in the midst of a COVID surge, the recommendation is to still stay vigilant. I know everyone is in a hurry to get their life back to normal, and I do understand people need to travel in order to see their families for emergencies. I would say to still stay vigilant. We're not out of the woods quite yet. Continue to wear masks and social distance, and we will hopefully go into clearer times as we get through this next surge.
Thank you, Dr. Lee. A follow-up question from Holly on Facebook, and she asks, any word on how the vaccine trials are going for children, and any idea when we might be able to expect them being approved?
I cannot say too much about how the vaccine trials are going on in children. I'm not caught up on that data yet.
I can take that, David. So I know that Pfizer is currently doing a trial, and that's for children between 5 to 12. I think they have completed their data analysis, and they are currently analyzing their data. They should be on the docket to the American College of Immunization Practices at the end of September to understand what that data is telling us in terms of the safety and efficacy of the vaccine. I know that Pfizer has been doing those trials using 1/3 of the adult dose, so I'm just waiting to see what the data says. So that would be when we would know more, closer to end of September, once they start sharing that data more broadly.
Thank you, Dr. Carla Pudi. Another question on the vaccine from Paula. She asks, many people are saying the vaccine is not protective against the Delta variant. People who've had the vaccine can get and spread COVID. Therefore, she asks, why should I get the vaccine, especially if it's not proven in stopping the spread?
The COVID vaccine, the Pfizer vaccine, the Johnson & Johnson and Moderna vaccines, we see between the vaccinated and the unvaccinated, we see those who are not vaccinated will get, when they get COVID, even though they get mild symptoms, at least 20 to 30% of them develop long COVID-like symptoms. We know that the vaccine, if you don't get vaccinated, those who are not vaccinated, they actually have a significant severe illness, and the mortality in people who don't get vaccinated is quite high. So to come to the conclusion that the vaccine is not effective because there are a few breakthrough cases and a very small proportion of these patients are admitting to the hospital only to go back home, would not be a full categorization of what we are seeing. The vaccines protect you from getting severe disease, and they are reasonably good in preventing even asymptomatic disease. But it is true, if you are vaccinated and you contract COVID, you are infectious, you will have mild symptoms, and very rarely you'll end up in the hospital. But unlike if you're not vaccinated, you'll end up, the people who are not vaccinated, like I said, have long COVID-like symptoms, and they also have a higher mortality. So I think the differentiation between the vaccine and not getting vaccine is very clear. The vaccine is very effective in keeping you out of the hospital, and even if you get into the hospital, the probability that you'll go home to your loved ones is much higher than those who are not vaccinated.
Thank you, Dr. Carla Pudi. And one more question for you on related to the vaccines. This one's from Hillary in Whatcom County, who asks, what are you recommending for older adults wanting to get a COVID booster shot and the flu shot?
Great question. On the flu shot, please get your flu shot. Please get your flu shot. It's still important to get immunized for the flu when the time is right. So that's one. The CDC has approved a certain category of people who will be eligible for their booster dose, and that happened, I think, in June or July. So please contact your primary care doctor. Ask them if you are in that category based on not just your age, but also your medical conditions, your risk factors, the medicines you take. Please contact your primary care who knows your medical history more thoroughly, and they can then recommend whether you need to get a booster or not based on what is currently approved by the FDA.
Thank you, Dr. Carla Pudi. I know I've heard you speak about the effects of long COVID in the past. First, can you talk a little bit about what long COVID is? And second, what do we know about its impact and what do we still not know?
Well, that's a great question. It's actually a silent disease that most people don't know about. So what we started to see after during the initial phase of the pandemic is people would get mild symptoms and they would recover, but they would not recover fully. We started to see stories of Olympic level athletes, professional players who would get COVID and then not be able to go back to even walking or running. And as this pandemic has evolved, what we are seeing that is anywhere between 20 to 30% of patients who even get mild disease from COVID tend to get these long-lasting symptoms where it's categorized by malaise, not feeling well, don't have energy, don't have people feel like when they stand up they might pass out, chronic headaches, and just weakness. So we are still defining this disease and understanding it, but these are manifestations that last way longer than what we would see just after that's why it's not like the flu, because flu doesn't cause all these long symptoms. So essentially we are seeing patients up to 8-9 months who have not gotten back to being themselves, who have lost their sense of taste and smell, and that doesn't come back for a very long time. So these are very long, protracted symptoms that make that actually essentially kind of don't allow you to function normally with these symptoms. We are still learning a lot about the disease. We're still trying to understand how people recover. It's still early in the pandemic, but it is a real thing. There are anecdotal stories of Olympic rowers who have not been able to row. A lot of professional level players who have gotten COVID and can't play at the professional level anymore. So it happens to very, very healthy people.
Thank you, Dr. Karlapudi. We had Greg send in a question in chat that said, if I had COVID, why should I get the vaccine? I don't understand why I should do that. And I believe that should probably go to you as well, Dr. Karlapudi.
Yeah, it's a good question. Based on the data we know, based on the published data we know, where we are looking at data that's been verified by people to understand, which is verified data, what we know is that the immunity that human beings develop with the infection is not as strong as the immunity provided by the vaccine. We know that those who have had COVID before and are not vaccinated, they are at least 2 to 3 times more likely to get COVID again compared to those from the same time who have actually been vaccinated with COVID. So the fact that you have had COVID before does not protect you as a vaccine would. And that is why if you still have had COVID, it is better to get the vaccine than to assume that you're protected from it. Because as we have seen these variants change, the previous infection could be from a different variant, right? And therefore, you might not have the full immunity to it, but the vaccine has the same protein that protects you much better than the original infection. And that's why you need to, it is very strongly recommended to get another vaccine, even if you had previously had COVID.
And on that note, I think a lot of a lot of patients are asking, when can I get my vaccine after COVID? And we are recommending after 30 days of your diagnosis, it's safe to get a vaccine.
Thank you for adding that, Dr. Lee. This question's for you. What do people need to know if they're treating themselves or a family member for COVID at home, and at what point should they seek medical care?
Yeah, so the symptoms of COVID, as we know now, are and again, not to be, I want to make a clear distinction that this is not the flu, but some of the symptoms are similar. You have shortness of breath, sore throat, generalized weakness, fatigue, muscle aches, and we do encourage people to stay home during this time, obviously, as much as possible. We ask you to seek medical attention if you're having problems breathing. I do like to ask patients to purchase a pulse oximeter to monitor their oxygen at home, because if it drops significantly, we would like you to come to the emergency room. Get lots of rest, drink a lot of fluids, and look into seeing if you qualify for the monoclonal antibody through your primary care provider.
Thank you, Dr. Lee. We're nearing the end of our discussion here, and appreciate all your help. We have a question for the entire panel, and it came from Deborah. We will start with Cedar. She asks, will things ever get better? Will they ever develop a vaccine for COVID that prevents you from contracting the virus by 100%?
I hope so. I think that, as we've seen with previous diseases, that we may have vaccines that help certain years, and certain years they may keep minimally at bay. Time will tell. If we can continue to decrease the prevalence of any variants, then I think that we can move in a direction that is safer, that maybe we can, as Dr. Lee was talking about, that we need to stay vigilant, but I think we may see a time where we can travel more freely, we can do things more freely, but I think that we have some work to do as a community and as a nation and as a world.
Thank you, Cedar. Dr. Lee, same question to you. Will things ever get better for us?
I wish I had a crystal ball and I could tell you where we would be a year from now. I think this time last year I was hoping things would be better at this time. I know everyone wants to get back to normal, and I know there are states where things appear normal, but I think the question right now is, what is the new normal? I think we're going to be dealing with this disease process for the foreseeable future. And like Cedar said, time will tell. And until then, we do need to just be as careful as possible and remember that we are still in a pandemic. And in order for things to go back to the way they were, we do need people to get vaccinated as much as possible until we can one day hopefully get to our old level of normal again.
Thank you, Dr. Lee. Same question to you, Dr. Carla Pudi. Will things get better for us?
I am optimistic things will get better. I think they will get better. The question is, are we doing what we can do to make things better? Because things don't get better on their own. The fact that we have 2 vaccines that are more than 95% effective when they became available within 9 months of a pandemic is actually close to the closest to a miracle that I've seen in science. Because before that, it took us at least 4 years to develop the measles vaccine. So it's not getting those 2 vaccines within 9 months of a pandemic itself is a miracle. So I think how we use and how we adopt and how many of our colleagues and community members get vaccinated will really help us find that hopeful normal state faster. So yes, I'm hopeful things will get better. We will find a new sense of normalcy, but it will need our help. We'll need to do our share. We will need to make sure we get vaccinated because they are very effective in preventing serious disease.
Thank you, Dr. Carla Pudi. I'd like to take this opportunity again to thank all our panelists for taking time to be here today. And thank those of you who tuned in to listen. I'd also like to thank all of you who sent in so many great questions for our panel to answer. I'm sorry that we did not have a chance to get to them all. Julie, I'll send things back over to you to wrap up.
Thanks, Dave. And thank you to our panelists for joining us today. So much great information. Thank you so much also for the work you do in keeping our community healthy. And thank you to our viewers as well. You had great questions. As Dave said, we had far more than we could get into this hour. We would love to continue to get your questions for future stories and perhaps another video event. You can email those to newsroom@bellinghamherald.com. Also, if you enjoyed this live event and have suggestions for others, please drop me a note at julie.shirley@bellinghamherald.com. If you're not already a subscriber, you can support our local reporting by joining us at bellinghamherald.com/subscribe. We will be posting today's conversation on our website and social media channels later today. Again, thank you so much for participating in this Bellingham Herald video event. Have a good afternoon.